Okay, it's just coming on now.
Can we start? Yeah.
Give me 2 seconds. I'm just waiting for it to say it's setting up.
All right.
Sorry.
That's all right.
Okay.
Hi, everybody, and welcome to the live stream for the power of data in health and social care. So today we have an hour. We don't need to use an hour, but we'll introduce ourselves and then we will invite questions. So if you've got questions, please feel free to ask them. We'll do our best to answer them. And we can just have a general discussion. So I'll introduce myself. I'm on the Future Learn page, so hopefully you've seen me. But my name is Marilyn Lennon, and I'm a reader and academic basically at the University of Strathclyde. But all of my research is focused on digital health, and a lot of that is around data. So I'm obsessed with data, but like many people on the course, I'm fascinated about how we can use data better. So I feel like there's lots to be done, especially in health and social care. So that's why I'm passionate about this MOOC, to try and upskill the health and care practitioners to do better things with our data. And I'll pass over to Jeanette Hughes.
Okay, thanks, Marilyn. Hi, everyone. My name's Jeanette Hughes. I'm Director of Planning and Performance for the Digital Health and Care Innovation Centre, which is a national Scottish innovation centre. So welcome. Delighted you could come along and hopefully ask some good questions. Just to give you a wee bit of background about myself, I've worked in digital health for the last 12 years, and I would say what I've seen is there's so much data. The question is what we actually do with that data to deliver better services for the patient and for professionals to make good decisions about the care for those that they look after. So I think there's a great opportunity here, and what I've realised, and Marilyn and I developed the course around this, is that actually all we need to do is actually harness the power of that data and upskill people to understand the potential. So delighted to answer as many questions that come out of this forum. So I'll pass back to Marilyn.
Thanks, Jeanette. So yeah, so please do ask us questions. We prefer when people ask us difficult or interesting questions. That gets us thinking too. But I thought I would start just by giving the results of the poll from week 1. So for all those that took part, we've got about 200 learners, I think, on this MOOC. And I know there's a few of you that I've noticed who are very active and posting lots of stuff. So keep that up for the last week as well. And we'll, Jeanette and I will jump in and try and have more conversations this week and next week with some of the discussions. But the poll that was in week 1 was around just basically asking you, out of all the learners, who is currently working with data? You know, who's doing this just because they're interested, and who's doing it because they have data in their organisation and they just don't necessarily know what to do with it. And 3/4 of you said, yes, you're working with data almost on a daily basis, which is really interesting. I suppose we all are, in a way. About 20% said no, and I think the rest were unsure, but I thought that was pretty interesting. And a lot of you were pretty honest by saying, you know, there's all this data. And I think somebody even used the expression, we're saturated with data, but we don't always know what to do with it. So I thought it was worth us discussing that, because Jeanette and I completely agree. We talk about this all the time. So in healthcare and in social care, and in the whole big world of consumer care as well, there's just, like, we've got Fitbits, smartwatches, phones, step counts, health records, disease registries. We've got things like police data, ambulance data, hospital data. There's just so many streams of data. And what I think people are trying to do is race ahead and do artificial intelligence on everything. And that's the kind of desire. And we want to do that too. But one of the things I wanted to ask Jeanette is, or just discuss with Jeanette, is, do you think we need to rewind a bit and actually tighten up how we collect our data so that we can get it in a kind of ordered, structured, sensible way, so that we can actually do the cool analytics later on? Do you know what I mean? Would you agree with that?
Yeah, no, absolutely, Marilyn. And I think, one of the points that you've raised at the beginning about the poll, about maybe 20% don't feel that they do anything or they deal with data. I think the reality is everybody deals with data every day. What you tend to find, depending on how you're working in health and care, or even as an SME, and I saw within the delegates in this cohort, there's quite a few companies working. It's actually, what you actually do to standardize the data, because obviously in standardizing the data, you have a much better data source to work from. And there's a lot that can be done, even just moving things from a analog, I suppose, a paper format and delivery into an electronic or a digital format. And I suppose we're seeing big movements with that, but you'll still be surprised that health and care, there's still a lot of bits of paper flying around and people writing things down, which can cause errors with data. And then there's data input for that paper, and then where does it actually end up? And then can it be analysed so that you can understand what the data is actually saying to you? I think you also touched, Marilyn, on the different kinds of data. And I suppose from my perspective, you've got kind of two major kinds of data. You've got closed data, which is very much used for health and care practitioners. It's very secure, rightly so. And then you've got open data and perhaps consumer data, which if you're a health and care practitioner, if you actually could see the closed clinical data alongside the personal data that we all hold about ourselves, how much activity do you do, whereabouts do you live, how many steps you do every day, to more of the lifestyle data. I think the secret is how do you actually maybe even merge those two data sets so that you get a more holistic picture of the people that you're looking after, but even maybe just of you yourself, so you can understand your own data personally. So it depends on the perspective, but there's just so much data. It's trying to understand where the opportunity is to make the best of that.
Yeah, I agree. And so we didn't pre-discuss this, but we've discussed it in the past, and I think what frustrates me a little bit is that I do understand why data is closed. Of course I do, because there's data safety, security, privacy, and there are mechanisms to get hold of, national data sets. So there's things called safe havens, which are, very secure, tightly controlled, and you can pay to get access to, a disease registry or a whole cohort of patients, for example, if you've got an ethical purpose for that data. But it does exclude a lot of people. So a lot of the data scientists and analysts really want to get their hands on this data to help health and care. And it's not straightforward to get it. So I feel like in the future, the near future, we might need to facilitate that access in a more open way. So still have it secure, still have it safe and confidential, but maybe to release, anonymized data sets.
Yeah.
Or at least moving forward, come up with processes and protocols that mean that starting from now, if we're collecting data, that we can opt in to provide our data. So, I mean, for one, I wouldn't mind at all if, my Samsung phone data was uploaded for people working in physical activity. As long as they weren't selling adverts to me or something because of it, I wouldn't mind. Do you feel the same, or do you think it's a personal choice about whether you opt in to provide data or consent to give data?
Yeah, I mean, I think consent is key, and I think possibly a lot of people will be using apps and using facilities where they actually are giving away their data, but they maybe just haven't realised, because obviously many people don't read the full terms and conditions when they actually sign up for an app. So like Fitbit data, where does that go? If it goes into America, they have different GDPR rules to what we have in Europe and within the UK. So yeah, I think it is a personal choice. And I think, the drive towards using that data will bring different infrastructure with it. So, DHI is certainly doing a lot of work around person-held records. and how, you know, you as a consumer of health and care services, where do you hold that data? And then how do you actually share it with the statutory service so that it can be used? And another thing that that we've done quite a lot of work around is the kind of social determinants of health. And as I said, clinical data, which I think represents about 20% of your whole life. So your clinical record that sits with your GP or the hospital is really representing about 20% of your life. And actually, again, if you can unlock all the other bits of data, so the environmental data, the activity data, your economic data, you know, that gives a better picture for the person that's trying to treat you from a health and care perspective, to actually understand you as a whole person. And I suppose then it comes back to, well, where does all that other data sit? Because it doesn't naturally sit back into the statutory service. So, I mean, we have a vision that the consumer should hold that data and should have the ability to share that data when they think it's appropriate. And again, that is very much consent driven. So going back to your original question, it has got to be about consent. You know, we can't go using data that we haven't got any consent for. But I think just now we're probably, again, a generation that hasn't been used to using that data for that purpose. I think if I think about myself, and I've got 2 teenage kids, you know, I think they give data away every day because they get a benefit. And that's what you've got to think about. What's the benefit that you're going to get back from actually giving your care and health provider that data, or allowing them to merge some data sets to maybe predict something in the future that might happen to you and prevent the crisis.
So I mean, like car insurers, for example, if you know, they give you a reduction in insurance if you're willing to, you know, have the black box and the camera in your car, so you're providing that data and getting sort of money off. And there's new models coming out all the time. So some gym memberships, if you provide, you know, your Fitbit data and your exercise data, they'll give you a gym membership reduction. So do you think we'll move to that in the future? Do you think the future is, you know, trying to find that benefit for the consumer as a patient, because we're all patients in some sense, the word when we're born, but so that, I mean, we could be really controversial and say that, you know, if you provide your data, you could potentially get, you know, access to care easier in the future. I'm not saying that's ethically correct, but do you think that's something that will happen with data in the future, or are we too far off that?
Yeah, I think that's probably too far in the future for me to comment. But I think, you know, if you think about it, if you could be the provider of data to the health and care service, they could probably personalize what they could offer you. So that's where the benefit would come in, rather than, I suppose, the opposite of that, where they, you know, they say, oh, you've got to, you know, do more steps, and that, you know, I don't think we'll ever get into that situation. But I think if you can provide data and you get a better service from that, I think that's what maybe consumers are looking for. And again, that's just taking the models that technology have today. You know, if you provide more data, you get a better service back because they understand your needs, and they can also predict your needs. I mean, we've all seen it, haven't we? You know, you go onto a website, you look for something, and then they can start predicting that you want to go on holiday, for example, and start showing you things like that. So if they could predict there was maybe a need for you to do whatever, they could actually start predicting the services that you require to prevent health and care crises later on. And we do that with a lot of kind of the falls market. So we look at falls and we try and predict if somebody in a couple of weeks could have a fall, and then we try and put a service in place before that fall happens. And that obviously prevents that person falling. It then prevents them going into hospital and so on. So,
and it could become, I mean, so the huge benefit then is prevention, clearly.
Yeah.
Ultimately, that's good for the person, but also, you know, for our healthcare system. And part of the motivation in using data more meaningfully is, you know, health efficiencies. Let's be honest, you know, we can't support a growing population that's staying well but might live with multiple conditions, you know, into old age, which is a great advance in science, but it's not sustainable. So we do have to be more preventative. But the other benefit that you mentioned is that it could be a much more personalised healthcare journey, couldn't it? If you know, you're getting services tailored to you and mine are slightly different based on my needs. So that's two really clear purposes for data analytics, to help prevent incidents happening, but also to react appropriately in a personalised way for different people.
Yeah. And I think actually it's moving it not just to react, but be proactive. You know, so how do you do proactive analysis so that you can prevent an issue later on? I think as well, you know, data will tell you a lot of things if you can do the analytics around it. And what it could do is it could start allowing you to develop services for the future. So again, you know, if you look at demographics and you look at population health, you could start to see, right, actually in 5 to 10 years, we're going to need more of these services because the cohorts that are coming through are going to be this kind of individual. So I think it's not just about what you can do with data today or even tomorrow, it's what can you do with data to plan better and develop and deliver better services for your customers. And that's not just health and care, that's also for, I suppose, small companies that are developing products. You know, if they can see there's a gap and there's a need for that, you know, they can predict maybe the kinds of products and services that they should be developing.
Yeah, I think that's a great point. And what's coming up next week, by the way, in case you've not looked ahead, and do join us for the next week's live stream if you can, is some of the more nitty-gritty predictive stuff that you were talking about. So, you know, we're on this course, we're not trying to turn you into a data scientist, but we will go through some of the actual AI methods, you know, the machine learning methods, like trying to do clustering, so we can cluster people, you know, into cohorts, doing things like classification, like trying to predict whether or not somebody would end up in hospital given a set of variables, whether somebody's going to fall, like Jeanette's example. So there are really good statistical methods for doing those predictive modelling things, and I think that's where the power is. But going back to our original point, I think we need to upskill people in the health and care sector and in the digital sector to get all their ducks in a row, you know, get the data stored in the right fashion. And one of the things that fascinates me about health and care is that it's not all structured data. So you've got things like notes, which are sometimes handwritten, surgical notes, audio files, brain imaging, you know, all of these things. But there are really sophisticated methods now for, you know, doing image analysis or codifying images like X-rays and MRI scans. So the power of AI is there. And so we just need to learn how to, you know, pick the right methods to build meaningful models instead of just trying to throw all the data into a big box, shake it around and see what's happening in the inside. So do you think there's anything we can do, you know, practically to help organizations to get AI ready in their organizations?
Yeah, I think that's a good question, because I think AI for most people that are on the front line is kind of scientific. You know, I don't think I think there's probably a lack of knowledge, and possibly not. I don't know who's sitting in front of me, so you might actually be AI experts. Apologies if you are, but I think there's certainly something, and I suppose going back to your point, Marilyn, there's something about us trying to get you guys to understand what AI is, because AI has been around for 10, 20 years. You might think it's something really new, but it's actually been here. It's just applying it the way that we're applying it to health and care is the new bit. And there is regulations around AI, so it's not as if technology companies are just going and doing their own thing and seeing what the artificial intelligence is doing with it. So I think there's a trust element with technologies like that, and there's an upskilling that needs to happen so that we can I suppose, promote such innovation comfortably. But as you said, you know, AI, there was a big, I think there was a big, what was that again, trial done in, was it China? They were looking at brain tumours, and the AI tool, you know, was finding the brain tumours maybe quicker than a human set of eyes. So there's massive advantages to it, but I think it's got to be used in the right way, and I think we've got to have trust in the system, because you know, people won't use it if clinical safety and harm, you know, is anywhere near that. So I think that's an important aspect. But yeah, there's lots of emerging technologies and innovations, and you know, also it's not just looking at one data set. I suppose it's how can you actually pull a couple of data sets together to paint a picture of something that you wouldn't see naturally if you were just looking at the data straight on.
Yeah, and that's the real power, isn't it? It's connecting the dots, and we are just humans, right? And one thing that the only thing that computers are better at than us is detecting patterns in a really complex data set. We start talking, you know, people talk about big data. Big data doesn't just mean a big database, right? It means that it's diverse, it's coming from all different systems, it's different types of data, and it's complicated and complex for us to, you know, we can't look at it in a spreadsheet. It's not that straightforward. So some of these tools are certainly helping us to identify patterns or relationships in variables, you know, that might help us to do more meaningful diagnostics or screening or prediction of, you know, disease pathways and things like that. So I think you're right. One of the people on the class, I think it was Vivian, but apologies if it wasn't, but somebody posted a really interesting point in week 1, and it was saying, well, something along the lines of, can we give people too much data? So on the one hand, I think the example that somebody said was, with all the tracking technologies, they're really good and they can empower us to be more active or drink less or have a healthy diet. But what if somebody is using like a mood app or a mental health app or you know, monitoring their blood pressure, for example? Could we become addicted to data? You know, can we get it? Could we have too much data? Would that stress us out or exacerbate our well-being if we're constantly quantifying everything about our bodies?
Yeah, I mean, I think you can get obsessed, can't you, with data? And I've certainly had apps where I start and I'm like, oh my goodness, I'm looking at the data every 5 minutes to see what it's saying about my steps, or I've actually got new scales and I'm weighing myself every, you know, 6 hours to see if my weight's fluctuating at all. But I think one thing about having too much data or not having too much data, it's not about having too much data, it's about the user interface and the visualization of that data so that the person actually can make sense of it easily. So I think usually what I see with innovation is that the data is getting pulled together and all the complex work's happening behind the scenes, but what the user gets is a very simple user interface to maybe tell them 2 things. You know, we're not trying to tell them everything with the data, and I think that's a key principle that's really important for data and for data analytics. It's not just doing the analytics, it's doing the visualization piece so that it actually becomes understandable, and also not just understandable, but people can then take action on the data. So if the data is saying you've got a dashboard and it's saying you've got 4 patients and, you know, 3 are green, you know, and 1 is amber going on to red, that's really the one that you want to focus on, and what action then takes place. Because what I do hear from some clinicians and some other service providers is they worry about what if we don't do something and the data's told us, because there's just so much of the information, and that liability piece sometimes plays in. So I think that's important to understand, you know, what do you do with the data? Not just, it's great to have all the data, what are you actually going to do and turn it into action?
Yeah, I think that's spot on. It's about, people talk about meaningful insights, because, you know, statistics, like you said, it's been around for a long time. It's not a new thing. We haven't just discovered data or numbers, and you know, historically we can use statistics in a meaningful way, or we can use it, and many politicians do this, to misrepresent, you know, what's underlying. So I think people quite rightly are making sure that in health and care that it's, you know, presented in the right way and used in a meaningful way. So that's definitely true. But you've mentioned a few times the human factor, and I think that's really important, because I love data, I love computers, I love gadgets, but the human factor in this is really important. So even if I have the most sophisticated AI or machine learning algorithms, there's probably somebody somewhere looking at that, like you said, to make a decision. So decision support systems that have got cool AI underneath them, very often, not always, but very often, will still have somebody sitting at a computer saying, what am I doing next? How does my care of this patient or this person change because of what that graph shows me? And so there is lots of opportunity around visualization and analytics, I think, that possibly hasn't been quite solved yet. So that's definitely something to look at.
And I think the easier you can make it to understand the data, the more value you get out of it. And I think that's the same for consumers and for health and care practitioners, because you've got to remember, within health and care, you've got really skilled practitioners and professional people, but they were never, you know, depending on when they went through their courses, they were never told how to use data and how to do data analytics. So this is just quite an emergent field for them, and they usually rely on their IT department or their business intelligence department to say, can you run me that report to tell me something about that cohort, or can you do some business modelling around that data? So I suppose it's trying to understand if you can use the tools, because the tools have become so kind of user friendly that you could actually do something with the data yourself. And I suppose Excel, and there's activities later on in this course, but Excel is a good example. You know, you can do quite a lot with Excel. Obviously, it's not as sophisticated as other tools, but it's quite a good starting position to see, what can I do with the data that I've got, and can I understand it from different views?
Yeah, I think that's totally right. And yeah, there's sort of freely available things like Python software, a programming language that a lot of people use to wrangle data, and something called R Studio, which, yeah, it's a programming language, but actually it's quite accessible. You know, if you know what you're doing and you know what you're querying in the data, you can sort of write short scripts to kind of link data sets and then pull out subsets of that data, which is a really empowering thing, right? It's not just computer scientists or data analysts that can do that now. So
yeah. And I think, I mean, again, I know that everybody's not from Scotland that's on this MOOC, but in Scotland, what you usually have in health and care is information officers. So you have local information officers that actually can run reports. And I suppose, again, going back to Scotland, we are quite lucky because we have an information service that centrally holds all the data. So in Scotland, we have all patient data from the minute you're born to, unfortunately, the minute you pass. And so there's enormous power in using that data if it's used properly. It's just trying to find what the demand is for it and how you can use it to provide better services and care.
Yeah. And so something I'm interested, you mentioned how international our learners are in this MOOC, and that fascinates me. So if you're on the discussion boards this week, I would love you, it's not a direct activity, but I'd love for you to give us an idea of, you know, what's happening in your organisation in the country you're from, because we love learning about the different proactive things that different countries are doing in terms of their data sets. Something you mentioned earlier, and I thought it was worth revisiting because there was a learner that brought this up, was that healthcare has made a lot of progress, like the clinical data sets, but why is social care data still lagging behind a bit? Like, what's going on there? Because in Scotland, we have a joint up health and social care initiative, but there doesn't seem to be a huge surge of, you know, connecting up social care and healthcare in a really easy, seamless way. Would you agree, or do you think things are changing in that area?
No, absolutely. And I think that's inherent of systems being separate. So what we have in Scotland is we have 14 health boards, and then we have 30 plus local authorities, which would be municipalities for those from Europe and around the world. And they have different systems. They have different needs for the systems. And obviously with legacy systems, it's been very hard in the past to connect them up together. And that interoperability often is the biggest barrier. Also, you know, a health board has a different reason for collecting data. It can be often quite clinical because they are a health board and that's their kind of key service. Where a local authority, if we think about care, it's usually social care data and it's getting collected for different reasons. So again, you know, with the emergence of integrated joint boards in Scotland, that's certainly pushing that agenda forward, but there definitely seems still to be a bit of a disconnect. And there is big programmes, I suppose, again, from a Scottish perspective, trying to look at that. But again, I think moving it to an international audience, I think that is actually commonplace internationally. So I deal with America and I've been to India and, you know, I've spoken at a few conferences and it doesn't, nobody seems to have cracked it. I think if you look at the kind of new models of data, and Estonia is a good example, where you've got an e-citizen and they've got an identity, and that identity then plugs into lots of different services, which actually does straddle health and care and everything else. So if you are on a benefit or if you need to connect it up to where you live, you know, there's lots of different joining the dots. So I would maybe urge, you know, people that are on the course to look at Estonia as just like a good example where they are trying to bring data together, and they're also trying to get you to own your own data more. So there's definitely a movement and a shift, and Finland are doing the same, and there's a lot of other international countries doing something similar. So it's not just Estonia, but that comes to mind as a good kind of best practice example.
Yeah, and you mentioned right at the start, and it brings it back like sort of full circle to the trust. So there's huge benefit to doing that, like connecting all our data sources, but then quite rightly, people debate, okay, the more data that's connected up about me as a citizen, you do get people that then become worried that, you know, a government knows too much about you and could somebody misuse that? And so there's a very sort of hot debate about you know, how that could be misused. But then in the class we talk about GDPR, and it sounds like one of these boring government legislation things, but every country has some level of governance around their health and care data, and quite rightly so. But actually all sensible organizations have some data governance, right? So, you know, financial sector has got huge amounts of governance, quite rightly. And so it's right that the data should be protected, but it's almost like it's not it shouldn't be harder to do things in health and care just because it's health and care data. We should just do the right thing with data, full stop. You know what I mean?
Yeah, absolutely. And I think, you know, that goes back to this kind of person-held record or person-held data file. You know, you should, I suppose the argument is that you should own your own data. And, you know, you can get access to your health records if you actually go and ask for them. No, not many people do. And actually, the likelihood of you understanding what the record said would be limited unless you're clinical. And that's the same for care as well. And I think going back to your point about trust, you know, some people don't trust government, some people don't trust commercial organisations, and there is studies and reports that recommend maybe there's a kind of third party in this equation, something that is like a community asset locked organisation that actually holds your data. So that means that they can't sell it, but you can actually then share that data with whoever it is you want. And it might not just be the health provider or the care provider, it might be your next door neighbour because you're going into hospital, you want to share with them, or it could be your brother or your aunt that's looking after you, or you want to share what's maybe going on in your life from a health and care perspective. So it's all about then where does the powers it, who owns the data. And sometimes it sounds easier if the person owns it, as long as the right security measures around it. And then they decide if they want to, if I want to share it with you, Marilyn, and I want to share it with my oncologist or whoever it might be that I go to visit.
Yeah, I think that's a good point. And in the GDPR poll, I was just checking on my notes there, but in the GDPR poll that we had in the class last week or this week, I can't remember, the top one from our learners, they pretty much all voted for consent. So they were saying, there's all these, security, privacy, legal right to use data, privacy notices, all those kind of things. And most people said consent is the first and foremost. So informed consent, transparent consent, but also a couple of people pointed out things like, the right to withdraw the data as well, the ability to withdraw data if you want to, which is not technically a hard thing to do. You just need to be able to track which data gets pulled from the database. So
yeah, precisely.
We're aware of that.
Yeah, and I think if you look again at some of the kind of leading countries that have allowed that person to own that data, then they can share it. So if I could share it with you, Marilyn, and then I could retract it. So maybe, we fall out or something and I say, no, actually, I don't want her to have that data anymore, so I can retract it. So I think it is giving the person the ability to share it, but also giving the person the ability to retract it and close that data and pull it back if necessary. So yeah, I think you need both.
Yeah, and the other thing that came up in the GDPR discussions, or that does come up generally, is sort of transparency and like being clear about the purpose of the data collection. So, if somebody, like going back to your app example, if it comes up in the app and it clearly states, look, Fitbit are using this data because they're trying to improve their service, I'll probably click consent. But if it's done sneakily, people quite rightly get suspicious. So I think there's a lot of work to be done around making clear what the purpose of the data collection is, and then consumers and patients and everybody will generally be a lot happier with the process.
Yeah, I think around privacy policies and terms and conditions of sharing data, they can often be quite complicated the way they're written, and a lot of people don't understand actually what am I signing up for if they actually read it. So I think there's definitely a movement to make that for the patient, carer, consumer, a plain English and very easy to understand document rather than a big legal contract. You don't want to turn up, you're looking after a 82-year-old in a home and you have to show them a big, long, complicated document. You just want to tell them exactly how will it be used, where will the data sit, who owns the data, and what to do, I suppose, if they've got any concerns around that data. So again, I think plain English terms and conditions is probably best practice as well.
Yeah, I think that's totally right, and especially in Scotland, but also globally and internationally, like making it accessible in different formats for different people. Not digitally excluding people either. Like if people need different ways to provide their data, then that comes into play as well. The other thing that came up on the discussion boards this week was around anonymisation. So there's lots of tools for anonymising our data. So, it wouldn't necessarily say this is Jeanette, where she lives, everything about you. You can kind of remove certain identifiers. So you can still do some clever analytics at a population level without individually, the analyst doesn't know Jeanette and who you are. You'd just be a data point, but in a good way, so you're anonymized, stripped back from that. So being non-identifiable in some analytics cases is really the key to being able to unlock more analytical power.
Yeah, and I think you can still tell a lot. Again, if you're trying to redesign a service, you don't necessarily need to know it's Jeanette and she lives here, but you might just need to know the area zone that she lives in, rather than just the specific address. So it's trying to bring up a couple of levels to anonymize it, and that gives obviously comfort that you're not going to trip up on the data sharing agreements. I mean, another thing I think for Scotland, but I think this happens all over the world as well, is actually sharing between organisations. A lot of our projects, which are innovation projects, if we move from one region to another and we want to share data, it takes quite a long while. And I think actually, you know, people having a greater understanding of why we do it, but also making that as easy as we can and have guidance on it is a key part, because it's sometimes quite a time-consuming thing to actually activate.
Yeah, I think that's exactly right. And it's, of course, it should be protected, as we said at the outset, but it should also be facilitated and done, you know, if it's done right, you can do it without it taking, you know, 2 years to get access to a data set, for example.
Yeah, it can often
Definitely
take a lot of
room for,
yeah.
room for improvement.
I wonder if there's any questions, Marilyn?
We're just going to check on our chat because we're still live with you, but we're probably going to finish shortly, but we're just going to check if there's any questions getting thrown at us. And if not, no, so we're not seeing any questions here, but if you've tuned in or you're watching this on playback, then please stick with us for the next week or so, because we'll have some juicier kind of machine learning and method stuff coming up. And we'll also talk more about the organizational stuff, especially from health and social care perspective. And from the range of people that we've seen engaging, there's some real expertise. So, you know, get on the discussion boards and, you know, give us some hard questions or give us some discussions, and we'll have another look at those and try and address some of those in our conversation with you next week. So please join us next week. It will be the same time, 4 p.m. GMT, that will be. And it'll be the same method. It'll be streamed via the link you'll see in your MOOC class in Future Learn. So from Jeanette and from myself, I'd like to thank you very much if you've managed to join us. And we look forward to seeing you on the discussion boards, but also live here next week.